Hello, everyone. Thank you for coming. Welcome to NAUTO's 39th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth, where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in the daily drawings. Now, let me turn the stage over to Norm Thurston, NAUTO's Executive Director. Norm, the stage is yours.
Thank you, Erica. It's a pleasure to be with you for our closing plenary for the day. This session will be focused on filling population health gaps through data linkage. It will be moderated and was organized by Trudy Millard-Krause from UTHealth. This session is sponsored by HSRI, Human Services Research Institute. We'd like to turn the time over to Leanne Kandura for just a brief introduction to HSRA's sponsorship of the session, and then we'll have Trudy take it from there. Leanne?
Human Services Research Institute is a proud sponsor of this session. Dedicated to improving systems that change lives, the team of experts at HSRI is driven by a passion to see all people live fulfilling, healthy lives as empowered, respected members of society. For nearly 50 years, HSRI has been supporting leaders and policymakers and the people they serve by crafting sustainable, community-based, person-driven solutions to complex challenges in health and human services delivery. The HSRI culture is upheld by principles supporting diversity and equity, and the team purposefully acts to understand and mitigate systematic barriers that have impacted communities throughout the U.S. The team works across all fields of health and human services, specializing in aging and disability, behavioral health, child, youth and family, housing and homelessness, intellectual and developmental disabilities, and population health. For over 20 years, HSRI has been at the forefront of health data, partnering with federal and state agencies to design, develop, deploy, and maintain systems that collect comprehensive healthcare data and turn it into useful analysis and user-friendly tools and visualizations. As researchers, the team knows how crucial it is to have clean and valid data. With expertise in methodological standards and measure development, HSRI creates data systems that are robust enough to shape policy and drive progress. We are proud to partner with NATO to make this conference happen and to increase the use of and impact from health data. Please enjoy this session.
Thank you, Leanne. Let's go ahead and bring Trudy on stage. Trudy?
Thank you, Norm. Thank you, Norm. Thank you. Welcome to our session on filling population health gaps through data linkage. I'm Trudy Millard-Krause. I'm the session moderator. We have 3 exciting speakers today to talk about ways they have approached using data to fill a gap in public health analysis, evaluation, or research. These speakers have identified ways to enhance population health through applying or linking state health department data from emergency data, registry data, or death data to data found in claims or other sources. So I'd like to start off with our first speakers, Brad Wheeler and Allison Young of the North Carolina Department of Health and Human Services.
Hi, thank you for joining us today. Brad and I represent the data office at the North Carolina Department of Health and Human Services, where we work across departments to streamline data practices. Today's presentation is an example of how our office used a novel approach to bring together data resources and expertise to address both a behavioral health and a public health need. Today, we'll explain how an interdisciplinary team utilized an existing data system to tackle a policy need by developing a data pipeline and a case definition for behavioral health holds. Our goal is to understand the extent and experience of emergency department boarding, which occurs when patients remain in emergency departments for extended periods of time, sometimes up to months, due to a shortage of psychiatric beds. This issue reduces ED capacity and is associated with negative patient outcomes, yet data on the problem are mostly anecdotal. Behavioral health issues have increased significantly in recent years, with ED visits for mental health and substance use rising 44% from 2006 to 2014. The COVID-19 pandemic further strained this system, and 32 months into the crisis, ED boarding was declared a public health emergency of its own. In response, DHHS prioritized enhancing behavioral health data infrastructure. Our data modernization efforts included better data storage, visualization tools, and data linkage to address behavioral health holds. We partnered with several entities as a part of this work. First, the NCDHHS Division of Mental Health, Developmental Disabilities, and Substance Use Services provides expertise and guidance focusing on behavioral health service needs. They are also a funder for the project. The NC Hospital Association represents hospitals, guiding data provision and validation efforts. NC Detect is the state's ED syndromic surveillance system. Indicator work using NC Detect data is overseen by the School of Medicine at UNC Chapel Hill and the Department of Public Health. DPH also plays the role of data steward. The data office acts as the coordinator and also provides analysts who model case definitions and create dashboards for decision-making. The behavioral health holds pipeline begins with ED data from over 100 emergency departments, which are aggregated and then de-identified and stored in NC Detect. Records are uploaded weekly to DHHS's Business Intelligence Data Platform. We focus on visits lasting at least 24 hours to define a hold. From these data, a master data set is created using SAS and Tableau to calculate 10 different metrics, 4 of which have been selected for display in a data dashboard and shared with stakeholders. The second part of the behavioral health definition is that the encounter must have a behavioral health related chief complaint. We classify the reason for the visit using over 80 rules to account for lingo and misspellings, and over 49,000 behavioral health related complaints have been identified. Some of the most frequent complaints include IVC or involuntary commitment, suicidal ideation, and overdose. We're currently validating this approach with hospitals to ensure our definitions align with clinical experiences.
Our team identified several metrics of interest based upon discussions with the work group. The first metric was behavioral health hold encounters to reflect the number of long encounters occurring in the health system. Next, we wanted to understand the community burden of these encounters, and we did that by calculating population rates by incorporating demographic data from the U.S. Census Bureau. This helps us to identify differentially impacted communities. The median length of stay metric is a proxy measure representing flow rate through the emergency department, identifying areas with consistently high ED stay lengths, providing a stable aggregate metric from variable data with outliers. Finally, we were able to develop a metric that lets us quantify the number of people sleeping overnight in the emergency department. This metric was often used to introduce a policy discussion, but it was also quite impactful. It's an average person-time density metric, and while that's a mouthful of words, it's quite the potent quotable. We were able to use the indicators to produce a multifaceted perspective for the behavioral health holds dashboard. Through a process of wireframing and user feedback, we were able to design a story view. The statewide overview section provides demographic breakdowns and county-level projections of encounters and population rates, and identifies communities with significant changes. The equity exploration page allows for detailed estimates by race, sex, and age group, with data suppression policies included. Additionally, we included an About the Data section to provide context on the source data, key limitations, and statements on data quality for our users. In the next set of slides, we will show some of our dashboard visualizations. Here on the left, we show volume and rates of behavioral health holds in a series of graphs. The statewide summary gives a profile of holds across demographic categories and by county. Top county level estimates are displayed, and changes from the same period are plotted against prior year and highlighted in a blue to red scheme. We also have visualizations showing monthly changes across key groups. Charts show us that rates of statewide holds have decreased most recently compared to the prior year, and that teenagers have less consistent patterns of holds compared to others. The county trend charts allow us to select multiple counties and look at changes and comparing them with peer counties, both with respect to county, otherwise geography or demographics. Likewise, we're able to look at changes in the median length of stay for a particular group, whether that be a median length of stay by county of residence, across levels of race or age. Median length of stay is another dimension that can be used in a quality improvement context. Changes in median length of stay can be an indicator of meaningful change in external bed capacity. The spikiness in BH hold rates in our 12 to 17-year-old group at the top of the upper left chart shows lows in the summer months before rebounding, which are actually lower than most of their parents, who would be in the 18 to 64 age group. This is consistent with patterns of seasonal variation that are shown in nationwide emergency department mental health utilization data reported over the past 6 years. This has been attributed to unique exposures and social stressors over the course of the school year. The patterns by race show higher rates of ED encounters in the African American population, which can be influenced by factors including access to care. On the charts to the right, expanding the view to all ages, patterns of behavioral health holds among African American and Caucasian females indicate a period of acute hazard impacting teenagers, with changing volume and rates reflected in both graphs. When we look at population rates on the right, we see a region of acute disparity that lasts from teens into the mid-30s, a broader disparity than might be seen by an observer tracking the volume of people setting foot in their individual emergency department. This dashboard has informed the process of expanding access to crisis resources across the state. Earlier this year, support for 17 new behavioral health, urgent care, and facility-based crisis centers was announced, with estimates of county-level burden supporting regional allocations. We're looking forward to working with a hospital partner to understand key aspects of our data model. One item is the discharge date field. We would like to know if the ADT parsing methodology is free of extra latency that could bias these estimates. As part of the state's Medicaid expansion plan, health plans are being designed to connect and coordinate care, and the addition of a new payer detail field will allow leaders to monitor measures for their plan members. Finally, we're working to incorporate large language models to distinguish behavioral chief complaints. We know that there's a long tail of unique complaints with extensive narrative text. An LLM expert can boost discrimination in this long tail and identify new terminology for us to review. We hope this presentation shows that syndromic surveillance data from statewide hospital partners can provide intelligence about the flow of behavioral health care. We've built a dashboard capable of displaying indicators over time to give context to the burden of behavioral health holds. We believe this data model gives us legs to use indicators within hypothesis frameworks as planners work to roll out resources to the system and hospital stakeholders implement quality improvement approaches within their existing work. Other jurisdictions should consider efforts to incorporate behavioral health surveillance into their planning and response activities. This can begin with strategic conversations about public health and behavioral health stakeholders that evolve into partnerships. Thank you. Please reach out to us now with our information here. Thanks again.
Thank you, Brad. Thank you, Allison. That was very, very interesting. I'm going to take a moment to ask a few questions to allow our audience to submit some questions. And my first one is, you use the term boarding as well as behavioral health holds. I'm assuming that's the same.
Allison, do you want to take that, or do you want me to take this?
I can take it, I guess. So there are some very specific definitions for boarding. And so typically, hospitals kind of have definitions that they use. And one of the partners that we're working with has a slightly different definition for holds, because they may not meet the exact definition for what they consider boarding, but they're still in the facility for quite a bit of time. So while they're measuring similar concepts, the actual definition itself can vary slightly in terms of duration of time.
Trudy, you might be muted.
I don't think I'm muted, but I'll speak a little louder. Does it, when you did this, did you differentiate between the 24-hour holds and what's often called OBS units or observation units?
So in our data, we have a couple of fields that we can look at. So we have this concept of timing that's built into our data, and that is actually derived from the disposition that's captured in the encounter. So actually a lot of our questions are sort of around the data quality of that disposition. In addition to that, the data model includes the chief complaint and then up to 26 ICD-10 codes. And so our data model leaves a lot of room for us to model and understand what a behavioral health hold might look like, the conditions that might be present in the chief complaint, as well as the diagnosis codes that are captured over the course of about 6 months. We receive resamples for every encounter. So we're able to track it over a few fields.
Okay, we have a question asking about the HL7 ADT model for hospitalizations and ED visits data.
Yes, so I'll just give a little bit of context about what happened in our syndromic surveillance system. Around the time of COVID response, the folks who have that sort of central repository that receives data from over 130 emergency departments, they implemented some improvements, and that allowed them to parse the ADT messages by this disposition status, and really allow us to understand the ED portion of a person's trajectory within a hospital encounter. The inpatients, for instance, might have multiple segments corresponding to each portion of their care. So as it relates to emergency department holds, having that emergency department length of stay allows us to understand the care environment within the ED, and basically allows us to ask that question around bed capacity within the ED.
Okay, we have another question from the audience asking about the dashboards. Can you talk a little bit more about the audience for the dashboards and how were they received?
I can take that one, but let me clarify. Did you say how are they reviewed? Was that the second part of the question?
How were they received by
received.
Your constituents? Yeah.
Okay, thank you. We have a work group that we have been working with that is guiding the development of this dashboard. And it has several members that are part of the Department of Mental Health, Developmental Disabilities, and Substance Use Disorders. And these individuals represent many different interactions with folks who are in this system of care. Some of them have a clinical background and are medical providers, and then others are working in the kind of organization and management of care stream. And then we also have some data analysts as well that are a part of this work group. And so the primary use tends to be geared towards policy and looking at maybe the impact of different programs that are being implemented, and seeing if numbers change over time as policies are enacted. And these are currently received as Tableau dashboards. They're internally received at this moment. We are exploring the potential of something that may be more widely distributed, and we're working through what we can and can't display with the data use agreement that we have with our partners.
Okay. And there's a question about the last graph to the right on the encounter rate. This question notices that there's a convergence between whites and African Americans around age 30, and wondering what causes this convergence.
I could take this. So that is a very interesting observation that we had noted too. We've found many things interesting in this work. The really high hazard in the teenage years, I think, is something that's caught the eye of some of our planners who are thinking about potential interventions for school-aged children and the availability of resources in school settings. I will say that our dashboard has a very wide range for its adults age group. It's like 18 to 64. And, this is something that, begs the question, does this make sense? I think we're able to present both views here. And I think we're going to be asking more questions. One of our stakeholders is hospitals as well, and they can help us validate some of these observations with ground truth, and to help understand factors that might be responsible for this. The equity analysis is one of the main purposes of this dashboard. Thank you.
Thank you, Brad. Thank you, Allison. We do have one more question, but we're going to hold that to the end with all the other speakers. So now I'd like to welcome Lee Spangler from UTHealth School of Public Health, Center for Healthcare Data, and the Executive Director for the Texas APCD. Lee?
Hello, I'm Lee Spangler. I'm Executive Director of the Texas All Payers Claim Database, and I'm going to discuss with you some of the legal aspects that might arise when you're linking two separate data sets. Before I get into the presentation, I want to bring to everyone's attention this excellent publication, Registries for Evaluating Patient Outcomes, that's made available by the National Institutes of Health. For those of you who may be lawyers or maybe just legally minded, this publication contains a great deal of guidance, especially on the legal aspects of linkage projects. It has a table 16-1, that contains a cadre of legal considerations that must be taken into account as the project moves forward. Many of those touch upon HIPAA, but I promise you I'm not going to talk about HIPAA except to say I'm not going to talk about HIPAA. I'd rather focus on the state level laws that also have to be considered whenever you're dealing with data linkage between separate data sets. So where to start? What are the legal considerations when linking particular data sets or trying to bring them together and maybe making a value-based data set that combines the two? Well, the first thing you have to do is ask yourself, why is everyone taking on this project to link the data sets or to merge the data sets into another value-based data set? That's a decent place to start any particular project. Why are you doing it? The answer to that question will provide the basis to answer many of the legal questions that are sure to arise. Why are you doing something can answer questions related to who's allowed to access the data. What use may those users put the data to? Are there prohibitions on certain commercial activity or commercial gain? What kind of disclosures are allowed? The classic example is patient identifiers, that you can never really identify patients in any particular research project. But what about provider identifiers? At one time, the Texas All Payers Claim Database organic statute precluded the identification of providers in any reports that came out of it. So let's continue to use the Texas statutes as an example to examine the legal framework surrounding, say, cancer data usage and cancer data linkage. Texas law allows APCD data to be used for research and other analyses by qualified research entities, which are defined in our Act, and the Center for Healthcare Data, which is where I work, as long as those usages comply with all applicable federal and state laws. So again, that's HIPAA's in there, but I'm not going to talk about HIPAA as I promised. This law provides answers to the questions such as who can use the data and how the data can be accessed. The data can be used for research and other analyses. So why are you doing this project? If you're doing it in order to research in cancer, you may have a purpose that is appropriate to use under this act. However, the law also imposes additional guardrails. For instance, the same section specifies that data usage must comply with the standards, requirements, policies, and procedures that are established by the center. So just getting over that hurdle of who and why is going to access the data doesn't necessarily answer all your questions because you have other considerations that might be in all of these particular areas. And so what that might mean for APCDs in other states, for example, you may have approval processes for use of the APCD that requires a series of approvals, including discussions with committees, boards, or maybe even just approval by an executive leader of some sort. But that's only half the story. When dealing with cancer registries, and again, I'm just using the cancer registry as an example, this issue would arise with any separate data set. You know, what separate set of statutes apply to this other data set? It's going to have its own organic statute that has to be considered as well. So, for example, the Texas Cancer Registry can be released for statistical purposes as long as it doesn't identify individuals with consent of each person involved. That's not really going to be very helpful when you're dealing with linkage between an APCD and a cancer registry, so that one probably wouldn't work. To promote cancer research, including sharing data with other cancer registries and appropriate state or federal agencies. Well, there's an example that might work with the Texas APCD and say the Texas Cancer Registry. This kind of raises an important question though. How do different legal mandates such as research and other analyses for use of the data at the APCD align with the promotion of cancer research, for example? And is an APCD established at a state university, which we are a state agency, an appropriate state agency for this purpose? Keep in mind, we are not living in a world where everything is mutually exclusive. So both purposes may be true at the same time and may motivate the persons who administer the differing data sets. So you can have many reasons for doing something that might meet a particular need, might meet a particular legal exception that would allow you to utilize the database, provided that there isn't something else in the Act that would somehow make that use a prohibited use, such as maybe commercial gain. And there's more. There's more to consider. Unwritten policies, often referred to as desk rules, often rear their ugly head right as you're about to get close to the end of a project, or maybe the beginning of a project, I guess, since we're talking about using and accessing the data for the project. So what are desk rules? Desk rules are unwritten habits, internal habits of the agency or decisions that can either support or hinder the linkage of the data between the two agencies. These informal mechanisms, sometimes based on adverse experiences that the agency has run into previously, or maybe it's just long-standing institutional memory, may not be codified, but they still will motivate how decisions are made by the agency itself. It's basically an internal guide that allows staff to interpret and comply with the formal statutes. It's the way things have always been done. If you've heard that once, I've heard it a million times. That's a common phrase that kind of pops up in these situations. This informal approach is born out of the need for certainty in ambiguous areas of the law, or the requirements to escalate certain specific issues to senior management for approval. If anyone really wants to gain some additional insight into what desk rules are, I would recommend Street Level Bureaucracy by Michael Lipsky. It's an old book, it's from 1980, but it basically describes how policy is made by bureaucrats' use of discretion, and sometimes maybe the limitations on the resources that they have available at their hands. So what to do when the gulf is too great? Perhaps you can't necessarily get the other agency to admit or agree that encouraging research in cancer is the purpose of the particular project. Well, when the law can't meet in the middle, maybe the researchers can. And there are various ways to link data between agencies without actually sharing the data itself. And I've got these three particular examples mentioned there. I can't really say much about them because I'm a lawyer and not a data scientist, but I know that if the two data set administrators have a trusted third party that actually creates an index that is de-identified, but can be used by researchers to access data separately between, say, the cancer registry and an APCD, that they can do so. The registry or other data set owner in the APCD itself, they can utilize the same method of hashing of identifiers, and then both produce lists that basically do the same thing that the trusted third party would do, which is an encrypted crosswalk between the two data sets. And there's also tokenization and other methods that I know are out there, but I'm not competent to speak into those areas. But when the lawyers can't do it, sometimes someone smarter than the lawyers, the researchers themselves, can actually get that done. And with that, I hope that you found my presentation to be useful. I look forward to any questions that might come to me on the panel, and I hope you all have a good rest of your day. Thank you very much.
Thank you, Lee. I understand that you in particular worked with the cancer registry in the state of Texas. It occurs to me that it's always easier to say no. So did you find the Department of Health and Human Services and the cancer registry were helpful and wanted to help find a way to make it work?
Yes. They take their charge, not just to protect the data that they have in the registry, but to make use of it as the legislatures commanded them to. It's motivating for them as well. So they really wanted to do it, but we kind of did run into that habit or desk rule where everyone thought, well, we've never really done this before. This hasn't been done this way. And all you can do in those kind of circumstances is just keep the dialogue going, because eventually everyone's working toward a successful end to the project, right? Or actually, we're talking about really a successful beginning to the project, even getting it started. And so those motivations turn into creativity or maybe flexibility because they're maybe dealing with a new party. APCD in Texas is new. So they had to think about it in a little bit different way than they had previously. If you really get entrenched, and our HHSC team didn't really get entrenched, but if you really get into a disagreement between the two parties, where one says, yes, I believe we can do this, and the other says we can't, the legal tools that are available to you are really not very good at resolving those kind of disputes, because legal tools are typically adversarial. And here we're trying to get a project going together. So you don't want to get into those adversarial kind of tool sets, because then you get bad blood, and you'll never really come to start your project.
Has there been a perceived benefit to both sides? And can you tell us a little bit about what that was for the Cancer Registry project?
Well, yes. It's like anything else. So from the APCD side, as is the case with most APCDs, there's a little bit of a gap, if you will, in that we don't necessarily have all of the information that a registry might have, because self-funded ERISA plans voluntarily submit to an APCD. But by the same token, a registry gets limited data in terms of, well, we've got some clinical data dealing with the diagnosis, what level of the diagnosis might be, things like that. But they can't really get a broad view over the whole state in terms of what are the follow-up, what is the follow-up for those patients that might not appear in the registry. Is there a difference between how people get treatment between rural and urban areas? Those kind of things might escape a registry, because they do have an idea of when the cancer was diagnosed, what level of cancer that was diagnosed at, and then how it kind of progresses, but they really don't get a whole view of the treatment. So we're excited that both sides will just get a better vision of how cancer is treated in Texas, and then also offer that crosswalk that I kind of talked about in the presentation, where other researchers can come in and actually do other creative research projects using both data sets. So we'll be doing our own research for sure, but I know that others would like to kind of supplement what's in the registry with what we'll have in the APCD.
Thank you, Lee. And to be sure that we give all of our speakers enough time for their presentation, I'm going to move on to the next speaker, but we will be able to come back to you with questions at the end. So let me take a moment now to welcome Alex Ma to the stage. Alex?
Good afternoon. My name is Alex Ma from Onpoint Health Data. Today, I will be talking about the study that we did using APCD and death certificate data to evaluate end-of-life and hospice care in the state of Vermont. I will first provide some background on the data that we used for this study. This work is based on claims data from the Vermont Healthcare Uniform Reporting and Evaluation System, also known as VCURES. This is the state's all-payer claims database, or APCD for short. I will refer to the Vermont APCD as VCURES throughout this presentation. Onpoint Health Data has been the data vendor for VCURES since 2008. VCURES contains medical and pharmacy claims, along with enrollment information and capitation payment data for the state of Vermont. External files, such as death certificate data, can be linked to VCURES to enhance the research capabilities of the dataset. For this study, we used death certificate data from the Vermont Department of Health to enhance the claims data. The death certificate data provides information about members who died during each year, including the date of death for each member, along with the location of death for each member. Whereas VCURES provides claims information for treatments provided during the year prior to death, along with the date of entry into hospice care for each patient. The linkage from the death certificates to VCURES was performed by matching member identifiers like first and last names, date of birth, and gender from the death data to hashed member identifiers in VCURES. Combining the death certificate data with the VCURES data creates a more robust data set that can be used to study end-of-life and hospice care. So why focus on end-of-life and hospice? From a health policy perspective, there is a major cost savings component. So in a study performed by the National Association for Home Care and Hospice, along with NORC at the University of Chicago, they found that hospice care resulted in $3.5 billion in savings for Medicare. More importantly, hospice care leads to improved quality of life for both patients and their families. Hospice and end-of-life care can improve pain control and reduce emotional and physical distress for patients, and reduce stress and improve the emotional outcomes for families and caregivers. So here are the measures that we use to evaluate end-of-life and hospice use. So we first identified patients who died during the reporting year using the linked death certificate data. This allows us to calculate mortality rates. We then, after identifying the patients who died, we can identify the first day of hospice entry using the claims data, and then stratify the patients by those who entered hospice less than 10 days before the end of life, those who entered hospice in between 10 to 180 days before end of life, and those who did not utilize hospice services before end of life. We can also, for the patients who died, identify their location of death and calculate percents who died in hospitals and percents of those who died in skilled nursing facilities or long-term care facilities. So here are the key findings from our studies. So the study was performed on 2022 Vermont data. In 2022, the Vermont death certificates included 6,012 deaths. So out of these, 5,504, or 91.6%, were linked to BCare's data, specifically to members who had medical coverage in 2022, which was a criteria for being included in our study. The majority of these members who died were Medicare patients. Out of the 5,504 deaths that were linked to BCare's, 4,627 of these were Medicare patients, or around 84%. You'll see in this table that the Medicare mortality rate is much higher than the Medicaid and commercial mortality rate. So the mortality rate per 1,000 members is 32.7 for Medicare, compared to 3.6 for Medicaid and 2.1 for commercial. Our next finding is that Medicare patients had the highest rates of hospice use. So you can see in this graphic, 48%, or about half of Medicare patients, utilize hospice before death. Compare this to commercial Medicaid, where you can see that the majority of people who died did not utilize hospice. Another finding is that hospice use patterns have remained steady over the years. So looking at this chart, which displays measure rates from 2020 through 2022, the percent of people in Vermont statewide who did not utilize hospice has remained around 55% from 2020 all the way through 2022. So this has seemingly remained consistent pre and post pandemic. Another finding is that Medicare patients are more likely to die in hospitals and skilled nursing facilities and long-term care facilities. So for Medicare, 45% of deceased patients died in a skilled nursing facility or hospital. Compare that to 27% for commercial and 24% for Medicaid. Last finding is that the rate of death has declined at skilled nursing facilities and long-term care facilities throughout the years. So in 2020, 27% of patients who died in a skilled nursing facility or a long-term care facility. This decreased to 23% for 2021 and 2022. So next, we'll talk about considerations for future work. So we will be performing this evaluation in Vermont annually moving forward. Some possible refinements to our methods include providing condition-specific reporting for complex terminal illness, such as terminal cancer, advanced dementia, and advanced congestive heart failure. We'll also look to exclude deaths that would be unlikely to lead to hospice, including accidents, overdoses, and homicides. And we will also apply risk adjustment for better comparisons between populations and across geography. Thanks for listening. I'll take any questions at the end of the session.
Thank you, Alex. We do have one question. How did you collect hospice care data, from the death data or claims data?
Yep, so the death data was just used to identify people who died. So yeah, we got the list of patients and their date of death and place of death. Hospice care and date of entry in hospice care was pulled from the claims data. So we identified hospice claims using a combination of place of service, procedure codes, and taxonomy codes that would be associated with hospice care in the claims.
You know, much of your study may have been able to be done just by claims data. What did you feel that you needed to start with the death certificate data, and how important was that to the overall study?
Yeah, great question. So for Medicare specifically, the death data is probably not necessary. So in the CMS, in the CMS like Medicare claims data, death date is provided for patients who died. So this study could be performed for Medicare without the data linkage that we did. For the commercial and Medicaid case, so we can't identify all the patients who died just in the claims data. So having the death date enhanced by the death certificate allows us to calculate mortality rates, and then from there calculate percent of people who died who got hospice. So yeah, not necessary for Medicare, but in this case necessary for commercial and Medicaid.
Can you expand more on your reasons for adding that as an enhancement?
Sorry, I think you cut out at the beginning of your question. Could you say that again?
Let me just skip to a question from the audience right now. How do you intend to capture data on specific conditions and risk in future reporting? And that question is very much related to what I just asked.
Okay, great. Yeah, so for specific conditions, diagnosis codes are in the claims data. So we generally identify patients with certain conditions just looking at the claims. For risk adjustment, we generally use Johns Hopkins ACG scores for risk adjustment. So that can be calculated from the claims data, and it looks at services utilized during the year along with gender, product type, and age.
One other question. Was your data adjusted for age? Most Medicare patients are over 65. Was it possible to find out if some patients have more than one insurance type, such as Medicare and commercial insurance, or Medicare and Medicaid?
Great question. No risk adjustment was done in this study. So yeah, we did not stratify by people who are dual eligible for Medicare, Medicaid, or those with Medicare and commercial insurance. That would be an interesting stratification for future work.
Are there any other questions from the audience? Okay. Should we bring back all speakers? Thank you. So Alex, there is one more question for you, and that is, did you use any fields from death data that might be missing or incomplete in claims data, such as race, ethnicity, et cetera?
No, we didn't use any race or ethnicity data from the death certificates. So race and ethnicity is definitely a pain point for claims data at the moment. In the state of Vermont, that is being enhanced, and the newer incoming data does actually have race and ethnicity populated. That's an enhancement for the future. But yeah, for this study, we didn't pull any of that information in from the death data that we linked in.
Hey there, this is Brad. I can take this one. So in the data we receive in our syndromic surveillance system, we do have like a high level indicator of, for instance, if there was a transfer, the type of facility, that is from it's classified by the aggregator. And so it's maybe not as specific as some of our behavioral health stakeholders might like. They tend to fund beds with like an ASEM specific designation. And so that's one of the realities we're trying to, I think, present back to our stakeholders. So in our encounter data, we do have some information on where those patients ultimately go. But at this point, it's very high level.
Thank you. One more question for Alex. Did you compare death certificates hospice indicator versus claims hospice?
We did not do that. I'm actually not familiar with the hospice indicator on the death certificates. So, but yeah, we did not do that.
Okay, do we have any questions or discussion among our speakers? Okay. Norm, would you like to rejoin?
Yes, thank you. Thank you, everyone. We do have about 8 minutes left. And so what I would, if it's okay with you all, we did this in the last session. I thought it was kind of fun to do. Just have each of the 5 of you take less than a minute and tell us, what do you think is the big topic that you're going to be dealing with over the next few months to a year? And let's start with Trudy. You get to go first, and we'll just go clockwise around.
Okay. Well, I think that for me, the biggest topic is going to be data linkage. We are exploring how do we link with HIEs, how do we link with these various registries, all to enhance the data that's available within the APCD and to really improve some of our research opportunities.
Right, very good. Alex.
Go ahead and echo what Trudy said. I think data enhancing the capabilities and filling in some of the gaps that we have in the APCD data. Pulling in HIE clinical results can greatly enhance measures reporting for many HEDIS measures. So that's something that's top of mind for me and other folks at Onpoint.
Lee?
Well, Trudy's right on our research side, but I'm going to be working with our legislature when they come back into town in January. So for the next 5 months, I'll be dealing with political issues that always seem to arise with data. Cybersecurity, I think, has captured the attention of a number of policymakers due to the United Health Group Change Healthcare ransomware event, as well as the Ascension Hospital ransomware event that they had. So therefore, large data sets, whether they're within the state, within the universities, or held by private parties, businesses, it's going to get a lot of attention. So I think cybersecurity and privacy is going to be a big deal from my perspective of the world, which is, the lawyer in me. I just can't get rid of it.
All right, Allison, take a crack at that.
Sure. So I think in our smaller sphere, we are going to be looking into validating our work and with hospitals. And so I think a lot of the work that we're doing is kind of continuing to be data linkage and how you are looking at data from different sources with different goals and purposes, and trying to align on how those data are communicated. And then I guess a little bit of Lee's too, with working in government, we'll be feeling administration change growing pains as well. So
that's great. Brad?
So I'll just mention that I think we mentioned in our presentation, but North Carolina was a late Medicaid expansion state. And I think that's really helped some of our stakeholders think about system improvements, how to use funding, one-time funding. I think we're going to be thinking very carefully about that, this year as we have, transition both within state government and then at the federal level to, make decisions that we think are as impactful as they can be right now. I think that's just generally some of the sentiment we have, but looking forward to see it.
Great. Well, I've just got a couple minutes left. I have a couple of housekeeping announcements that you can all be part of. First, we're going to put on the screen the winner of our daily drawing is Hannah Murphy from Vizient. Hannah's won a $25 Amazon gift card in the token hunt game. And we will have another drawing tomorrow during the last plenary of the day for 25. But on Thursday, during the last plenary of everything, the drawing is going to be for 250. So I encourage you all to get in, get as many chances as you can by doing the collecting tokens. Tomorrow morning at 11:30 a.m. Eastern time, we will open our virtual coffee shops. And there is no topic, there are just people. So just show up, talk to people, make friends. You don't have to bring coffee because none was going to be provided for you. You can either bring it or not bring it. That's up to you. So it's on you. Feel free what to do about that. But we'd like to see you tomorrow at 11:30 for that. And then we'll get started right after that. And then we have had a few questions about slides and information about things like that. So the recordings are available about 20 minutes after the end of each session. So if there's something that you missed in a session that you want to go back and freeze frame on something, that will be available. All of the sessions are recorded and they will be available about 20 minutes after the end. For the slides, we are going to collect slides for those who are able to provide them. After the conference, we will send you out a notice, I guess, to all attendees as to where the slides can be found. But I think you can appreciate guaranteeing that we can get everyone's slides in the right time, in the right place. It's going to be a little bit tricky, but we'll do the best we can to make those available. And then the last thing is just to make sure that you are paying attention to things like the announcements and the wall. The wall is a great place for you just to kind of dump your thoughts, just to say hello to friends and network, meet people. So hopefully you'll be able to take advantage of that as well. So with that, I think, Trudy, is there anything else we ought to do before we wrap up for the day?
Nothing that I have. I just want to thank all of our speakers for this presentation. It was very entertaining and very interesting. Thank you.
Okay, thank you. We'll see you all tomorrow at 11:30.